This is a UNAIDS mode of transmission study done just earlier this year, which indicate that some 30% of our new cases in 2012 are going to be among the MSM group. And some 7% further are going to be female partners of MSMs. So we have to target these groups. We have to reduce stigma so that persons from the MSM community will feel that they're able to come to see us, they're able to access treatment and care. Look very quickly at the national guidelines. They indicate quite clearly when we should start at a CD4 count under 350 or if the person is symptomatic. The guidelines indicate that we can start with other conditions, for example, in pregnancy, HIV-associated nephropathy, or with hepatitis B co-infection. So we would start earlier than the 350. So although 350 is a guideline, it's not in stone. We have to take it on a case-by-case basis. In the older patient, an interesting discussion we had as to what constitutes the older patient. Some young people thought it was anybody over 50. The USA, the European guidelines say persons over 60. If there's a rapid decline in the CD4, so that is falling by 100, 150 per year, or if there's an extremely high viral load, say over 100,000, then some persons would start these persons regardless of the CD4. What do you start with? The recommendation is tenofovir, emtricitabine, or the zidovudine, lamivudine with either efavirenz or nevirapine. But the tenofovir, emtricitabine, efavirenz is the preferred combination for reasons of excellent response and less in terms of adverse effects than the combination with nevirapine and zidovudine, lamivudine. But this is also acceptable for first line. In terms of monitoring, we do not do the viral load at the initial assessment. We do the CD4 at baseline initial assessment 3 months later, and then at least every 6 months. The viral load is recommended 6 months after initiating antiretroviral therapy, and in a stable patient yearly. Again, these are guidelines, and as practitioners, if we feel that our management would be assisted by doing these tests more often, then we should do it, as we would with any other condition. How do we measure failure? Well, we prefer to use virologic failure. And the guidelines indicate that that's a viral load of more than 400 copies per mil after the patient has been on the medication for at least 6 months and is adherent to the medication. This figure, some persons think, should be up to 1,000 mils. WHO says it's up to 5,000, but we're a little more conservative. Immunologic failure, falling CD4 count more than 30% in 6 months, and clinical failure, occurrence of HIV-related events after 6 months on therapy when the patient is adherent with the therapy. So virologic failure is preferred because it occurs much earlier, so that you would get virologic failure maybe 3 months before the CD4 starts to go down, and maybe another 3 months before the patient becomes clinically unwell. So we want to try and diagnose failure at that stage. The recommendation is check adherence, make sure they're taking the correct dosage, and you'd be surprised as to what and how persons take. Look at drug interactions, repeat it. If it is above 400, then change as soon as possible. But adherence always has to be an issue, always has to be looked at each time. And what do we switch to? Well, you switch to the other NRTI combinations, and then because there is cross-resistance in the NRTIs, we can't go from the efavirenz to the nevirapine or the other way around. So we have to introduce a new group, which are the PIs. But we'll look a little further at that. To switch gears in terms of prevention, which I think is an integral part of treatment, prevention and treatment, and a landmark study just last year indicated that treatment is prevention, and that treating the person, controlling the disease and keeping the viral load low does prevent the passing on of the disease. Positive prevention has to take a whole new emphasis. In the past, our prevention efforts were focused on persons who are HIV negative and trying to change their behavior to ensure that they don't put themselves at risk. Hasn't really worked. Behavior modification is tough, doesn't work, doesn't seem to be sustained. We have really no good studies that indicate how to do that and how to do that well. So we have to shift a little bit and our efforts to persons who are positive and work with those persons to ensure to maintain their health and to maintain the health of their contacts and families. So a set of strategies that aim to protect sexual and reproductive health of persons with HIV, acknowledging that they are having sex, they do want to have families. They have to protect themselves in order to delay the progression of the disease and to share with them the responsibility to reduce the risk of HIV transmission. Every person infected was exposed by HIV positive, and every infection really is a failure of prevention. And we have some 2,000 odd failures of prevention yearly in our country. So positive prevention includes a brief risk screening assessment with all HIV positive persons, talking with them about modes of transmission, STIs, pregnancy, screening and treating other STIs, and discussing reproductive health and family planning with our patients. Then providing brief interventions to reduce their risk, whether it's risk of STIs, risk of drug abuse, risk of violence, whatever. And most often this is a brief focused HIV prevention message. And finally, the third step is notification and counseling of partners. Speaking to them about disclosure to whom, when, how, disclosure to their partners, to their other family members, talking about adherence. So a 1, 2, 3 step really. Screen for risk behaviors, risk reduction intervention, and then encouraging notification. 5 minutes of our time. Follow up just a few minutes more. But remembering risk is not static, so it's something that we have to do at every intervention. We should include it. Post-exposure prophylaxis, that's in the guidelines also. Remember what the risk is, 0.3% if there's a percutaneous injury, 0.09%, so it's relatively low compared to sexual transmission or mother to child where there's no PMT-CT. Significantly more for the hepatitis B and C virus than for HIV. Can you
go back to that slide? It's too quick.
Too quick? Or how am I doing for time though?
Don't worry.
It's in the handout, right? No, not that. So it's going to be online, and then the slides will be gone, so you'll have it. And you'll have more than I've given here because I've switched it with a little other boring program stuff. So it does list what we should do with exposure. If it's mucous membrane and or the skin is intact meaning no percutaneous injury, no eczema, nothing that breaks the skin, then the recommendation is a 2-drug regime. If there is percutaneous exposure, the 3-drug regime. It does indicate what is recommended in terms of the 2-drug combination therapies. This is simply because we have the greatest amount of experience using the zidovudine-lamivudine combination. Other combinations probably work though and are easier to take perhaps over the long term. Remember, it has to be initiated in 72 hours and it should be continued for 30 days. This is a 3-drug regime, so we add the PI, a boosted PI to that regime. 72 hours and for 30 days. In terms of other prevention activities, PMT-CT of HIV and syphilis, we're doing a lot of work. The 2015 vision is that it should be eliminated in terms of mother-to-child HIV. No new cases of pediatric HIV by 2015, And the cohort of children who are getting older will have transitioned into adult care. In order to facilitate that, the guidelines have been updated, and they are buttressed by the fact that we know that pregnant women with a CD4 count less than 350 account for about 40% of the HIV pregnant population, but they account for 75% of the mother-to-child transmission risk, account for 80% of postpartum transmission, that's with breastfeeding, for example, and 85% of maternal death. The strategies to prevent that, therapeutic interventions, triple therapy, no. Used to be in the past just 2. Single dose of nevirapine orally at onset of labor, and antiretrovirals for the infants. Again, you'll get all of this. So all women attending a health institution for HIV care should be tested. An opt-out approach again. Test is only not done if the client refuses. HIV negative women should be retested because they do still become infected. And the syphilis test is also repeated in the 3rd trimester. Antenatal follow-up is done at high-risk obstetric clinics, at least once per month until 28 weeks, and then every 2 weeks for 36 weeks, and then weekly until delivery. We advise no breastfeeding if replacement feeding is feasible, affordable, sustainable, and safe, which it is in our setting, generally speaking. And mixed feeding should be avoided at all costs. Voluntary male circumcision is something that we have to look at very seriously in our setting. There's strong scientific evidence that it works, and works very, very well. There is epidemiological and biological data. There are random controlled trials done in many countries that have come out recently. There's a strong association between lack of male circumcision and a higher risk of heterosexual, so far not homosexual transmission, HIV transmission. And male circumcision has a strong protective effect against HIV acquisition. It's thought to be about 80%. Reduces urinary tract infections in infants. Syphilis is reduced 3-fold. 2.5 increased risk of chancroid. 63% reduction in human papillomavirus infection. 22% more frequent penile cancer in uncircumcised. Cervical cancer more frequent in women of uncircumcised partners. If we had a vaccine with this sort of data, we'd be pushing that vaccine everywhere and anyhow. So we need to look at voluntary male circumcision. So I end up where I started, in that this is what we're aiming for. A healthy patient able to have a healthy family. And this is a new face of HIV. This is what we're going to face. We're going to face attractive, obese men having sex, hopefully having protected sex with our intervention. I'm sure you recognize Magic Johnson, who's been around longer than most of us and has been HIV positive or declared so since the 80s. Continues to lead an active lifestyle. But to end, the way forward has to be a significant, structured, robust participation between private and public sector. A participation which is based on guidelines that we all follow, and based on the fact that all of us practitioners will have at least a minimum exposure and knowledge of how to treat this chronic disease, and be able to treat it very comfortably. And we have to look at accreditation, perhaps. Thank you very much.